are going to continue our cardiovascular unit with hypertension and heart failure. So let's talk about hypertension first. High blood pressure, hypertension. Well, first off, we're going to have two kind of broad categories of hypertension. We've got primary hypertension and secondary hypertension. Let's chat about primary first because it's primary. So primary hypertension, also called essential hypertension. We don't really know what causes hypertension in these patients. Most of your hypertensive patients are going to have primary hypertension. Um, but there's no just kind of pinpoint cause. This is exactly what's causing your high blood pressure, sir. So we don't really know. There are some theories, right? Maybe there's some weirdness going on with the renin-angiotensin aldosterone system. Maybe it's just natural sodium retention, and or maybe there's some wonkiness with sympathetic tone. So there's just some theories behind primary hypertension, but most of your hypertensive patients who have been diagnosed with hypertension probably have primary hypertension, and we can't pinpoint exactly what caused that hypertension. Compare that to secondary hypertension. Well, in secondary hypertension, we know we can pinpoint exactly what is causing this high blood pressure. If you look at pregnancy-induced hypertension, right? We've got preeclampsia. Well, we know exactly what caused that hypertension. Maybe they're on a very high sodium diet that's causing this hypertension. Maybe they're taking some medications. If they're on, chronically on steroids, they're prescribed steroids for a long period of time, you will develop hypertension, but we know exactly what caused it. So that's our secondary hypertension. Your patient has hypertension, has high blood pressure, well, we want to fix that. We want to regulate blood pressure. So how do we do that? And my lord, all right. Oh gosh. So, well, what is blood pressure to begin with? So let's look at the top here. What is blood pressure? Well, blood pressure is cardiac output times peripheral vascular resistance. So if we want to change blood pressure, either way, here we're talking about hypertension, we want to lower it, but there will be instances where we want to increase blood pressure while we're still going to be playing with cardiac output, playing with peripheral vascular resistance. So, well, what's cardiac output? Cardiac output is stroke volume and heart rate, so we can break it out even more. So, what is affecting all of these individual variables, and then which one is kind of going a little wonky, right? And that's how we can zero in and pick a medication and pick the best medications for your patient to treat this high blood pressure. So is it a stroke volume issue? Is it a heart rate issue? Is it a contractility issue? Is it a resistance issue, right? Is it sympathetic tone? Is it in that renin-angiotensin aldosterone system? So what we're doing here is just breaking apart exactly what blood pressure is and seeing which part of this equation might be the issue. Now let's get into some actual medications. We'll start with our sympathetic drugs, so drugs that affect our sympathetic side. The first, probably most commonly prescribed and commonly seen for hypertension can be your beta blockers. And remember, thinking back to beta blockers, we have selective beta blockers and non-selective beta blockers. So we have cardioselective beta blockers like atenolol and metoprolol, and then we have non-selective beta blockers like propranolol. Right. Our non-selectives are going to affect both beta 1 and beta 2, but our cardioselective ones, atenolol and metoprolol, those are going to just zero in for the most part. They're not completely selective, but for the most part, zero in on beta 1, and that's where we want to see the effects. If we're giving a beta blocker for hypertension, we want to affect the cardiovascular system, so we want beta 1 effects. There are also other sympathetic receptors that we can kind of play with, tickle, or block. So your alpha 1s, if we tickle alpha 1, if we stimulate alpha 1, we get vasoconstriction. We increase vascular resistance. If we're trying to drop blood pressure, we want to vasodilate and lower vascular resistance. So if we block alpha 1, we'll see some vasodilation, and we will be seeing decreased vascular resistance. Might see Minipress, might see Cardura. That's probably the more common one that's been prescribed out there. These are not first-line medications. Patient goes into the physician's office for their checkup, says, "Hey, you've got hypertension. Why don't we throw you on an alpha 1 blocker?" That's not the first line. This is kind of a few rungs down. But if you see these drugs, Minipress or Cardura, that's an alpha 1 blocker, hopefully hoping to decrease vascular resistance. Finally, we also have alpha 2. So if we stimulate, tickle alpha 2, what happens? Well, alpha 2 is kind of our mediator in everything, right? It's kind of our sober friend. So we always listen to our sober friend, and when we stimulate alpha 2, it kind of tells the body to just slow it down on that norepi, right? Let's watch that norepi. So decreases excretion of norepi. So if we tickle alpha 2, we're going to see some vasodilation. We're going to decrease vascular resistance. So a couple drugs and the alpha 2 agonists. So with agonists, we are stimulating. We're not blocking. We're stimulating these receptors. A couple medications here for you to be familiar with is clonidine and methyldopa. Both these drugs, again, are not first-line drugs for hypertension. These are kind of last-ditch efforts for hypertension. Um, Typically, the last, if not, close to the last, if not the last, line of medication that your patient will be on when their hypertension is high blood pressure, just resistant to all other treatments. Explore some other medications for hypertension. We run into calcium channel blockers. Mechanism of action, they are blocking calcium channels, and they block calcium from getting into cells, and um, and a shift of calcium inside and outside of the cells. For this, for treating hypertension, we've got nifedipine, we've got amlodipine, we've got sometimes verapamil to treat hypertension. Nifedipine also seen as Procardia, amlodipine also seen as Norvasc. Those are two. Norvasc is very commonly prescribed. Procardia is a little bit of a kind of a heavier hit. You might even see nifedipine as a drip in the ER, in the ICU, or on a critical care truck or helicopter. If we remember back, we know that calcium channel blockers come in two flavors. We've got dihydropyridines and we have non-dihydropyridines. And, well, which one is which? Well, our dihydropyridines affect the vasculature. Our non-dihydropyridines are going to be affecting the heart primarily. So for blood pressure regulation, we want to focus on our dihydropyridines because we want to be affecting vascular resistance in this case. And lastly here, let's talk about some other drugs that could be given for hypertension, for high blood pressure. First are just kind of our broad vasodilators. So they're just systemic vasodilators that your patient might be on. You might see hydralazine, might see nitroprusside. Nitroprusside you also might see in the hospital as a drip in the ICU, in the ER, and again on critical care trucks or helicopters. Maybe a 911 service here or there might carry nitroprusside or nifedipine. But if you see nitroprusside, it's just kind of a standard systemic vasodilator, and also minoxidil, which is kind of a fun one because this is not the most common use of minoxidil. Is not as a vasodilator, is not for hypertension. Minoxidil is Rogaine. It is it's used for hair growth because when they're testing it out, they found that a very common side effect was hair growth when they're testing it out for hypertension. So patient might be on minoxidil for hypertension, or it might be on minoxidil for hair growth. So if you see this on their bedside table, just ask your patient what they're taking it for. And kind of lastly, your patient might be on diuretics, and we're going to really dig into diuretics in a different lecture. But they might be on diuretics not for the diuresis portion of it, but for control of their hypertension, of that high blood pressure. So diuretics are going to remove sodium. Water goes with sodium, so they're going to lower their blood pressure through that mechanism. We've got thiazide type diuretics like HCTZ, hydrochlorothiazide. We've got loop diuretics like Lasix or furosemide, and we have potassium-sparing diuretics like spironolactone. So if you see any one of these on your patient's side table, again, good patient history, good patient assessment. Why are you taking HCTZ? Is it for the diuretic portion of it? Do we need to be losing bodily fluid, or are we taking it for hypertension for high blood pressure?